have a Q&A session at the end. We have some questions already coming through, so I would just encourage you to keep submitting questions. We'll have a lot of time at the end to go through all of this, and all three speakers will still be there. It's now my pleasure to introduce Heather McArthur, we saw right at the beginning of the meeting, who's the only one on stage physically today. Heather from the UT Southwestern in Texas will talk about immune therapy in the neoadjuvant or adjuvant setting in triple-negative breast cancer. Heather, over to you, please.
Thank you, Peter, for the kind introduction, and thank you to the organizers for including me in this terrific program. It's really a stellar lineup of speakers today, and it's wonderful to be included. I will be going over, I'm going to pivot on what Rebecca just shared with us, what we learned in the metastatic setting, and of course, whenever we have innovation in the metastatic setting, we try to apply those same strategies in the curative intent setting to see if we can improve cure rates. And so I'm going to focus on those strategies right now for triple-negative breast cancer specifically. There we go. These are my disclosures. And I'm going to start at the beginning. I'm going to start with the I-SPY 2 trial. And as you'll recall, that is a study that has an adaptive randomization. It's designed to look for estimated pathologic complete response rates. And in one of the arms of the I-SPY 2 trial, pembrolizumab was co-administered with paclitaxel prior to anthracycline and cyclophosphamide administration in the neoadjuvant setting. So it's worth noting that pembrolizumab was only administered with Taxol, and it was only administered with paclitaxel for those first 12 weeks. And what did the investigators show? Well, they demonstrated an improvement in the estimated pathologic complete response rate from 20% to 60%, so a threefold improvement in estimated pathologic response. So this was the first signal that there was a role for immune therapy for the treatment of early stage triple-negative breast cancer, and that we might actually be able to achieve improved cure rates. And what was equally interesting, and this became a story that sort of repeats itself as we go through some of the other studies, but that even patients who did not achieve a pathologic complete response still derive benefit from the addition of pembrolizumab. So one of the next studies that we saw was the neotrip study. This is a modestly powered study with 280 patients who were randomized to receive carboplatin with nab-paclitaxel. Nab-paclitaxel was administered 2 weeks on, 1 week off, and either atezolizumab or not prior to surgery, and the anthracycline was administered after surgery. Atezolizumab, again, in this case, was only administered with the neoadjuvant nab-paclitaxel and carboplatin. And these were the findings. There was no improvement in pathologic complete response with the addition of atezolizumab, and in interrogating subsets, including PD-L1 positive and negative, there was no difference noted. So having seen pembrolizumab and atezolizumab perform very similarly in the metastatic setting, how do we reconcile the neotrip study that used atezolizumab with the I-SPY 2 trial, which incorporated pembrolizumab? Is it a function of the estimated pathologic complete response rate from I-SPY 2 versus true pathologic complete responses? Is it a function of power with relatively small studies? Are these just accidents? Is PCR the right endpoint for IO strategies? And we'll come back to that question over and over again. Is it an issue of paclitaxel versus nab-paclitaxel? There was a lot of debate over the years about the use of steroids with paclitaxel and whether that would impede immune responses, or is it the carboplatin co-administration in neotrip? Was that important? In neotrip, as I pointed out, the taxane was administered 2 weeks on, 1 week off. If dose density is truly important, is weekly administration as a backbone important? And in neotrip, the anthracycline was administered after surgery. So there was some time between the taxane administration and the anthracycline, whereas in the I-SPY 2 study, they were administered together sequentially prior to surgery. And as Rebecca Dent just pointed out, the Tonic study, which we'll talk about a little later on, suggests that maybe anthracycline administration with immune therapy might be critically important. So a lot more questions than answers with these initial efforts. And then we saw the GetBar Nuevo study. This was a study randomizing patients to receive nab-paclitaxel, followed by anthracycline with cyclophosphamide with either durvalumab or placebo. A subset of patients in this modestly powered study did receive a run-in with durvalumab prior to initiating chemotherapy, and that may be an important design feature of this study. There was an almost 10% improvement in pathologic complete response, but it was not statistically significant, and that was the primary endpoint. So the study did not meet its primary endpoint, and in looking at the various subgroup analyses, there was no clear subset of patients who seemed to derive benefit. But what's been interesting has been the updated longer-term follow-up from that study. So we recently saw at the last ASCO meeting a more than 8% improvement in invasive disease-free survival. And this harkens back to my earlier point that maybe pathologic complete response is not the best surrogate marker for long-term cure rates for IO strategies specifically, because again, in this study, it did not meet its primary endpoint of improvement in pathologic complete response. So this was a striking finding, with striking improvements in distant disease-free survival and overall survival, more than 10% improvement in 3-year overall survival with this strategy. And again, similar to what we saw with the I-SPY 2 data, patients who did not achieve a pathologic complete response seemed to derive benefit from the addition of immune therapy to chemotherapy. This brings me to the Impassion 031 study. This is a study looking at nab-paclitaxel followed by doxorubicin with cyclophosphamide, plus atezolizumab or placebo. Again, a primary endpoint of pathologic complete response in the ITT population and PD-L1 positive subpopulation. The slides are not advancing. Oh, now we're cooking. Okay. Still not advancing. There we go. Okay. So we did see an improvement in pathologic complete response in the Impassion 031 regimen with the addition of atezolizumab, and benefit was seen regardless of PD-L1 status. So as Rebecca Dent just told us, that the impact of PD-L1 status in the metastatic setting does not translate to the curative intent setting. I think so. So that brings us to the Keynote 522 study. So this was the first large randomized phase 3 study enrolling almost 1,200 patients to receive neoadjuvant chemotherapy with either pembrolizumab or placebo. If patients were assigned to the pembrolizumab arm, they continued to receive pembrolizumab in the adjuvant setting for an additional 9 cycles. It's worth noting the chemotherapy backbone here because it involved 4 different cytotoxics: paclitaxel, carboplatin, anthracycline, and cyclophosphamide. So a lot of chemotherapy being administered here. Primary endpoints were pathologic complete response and event-free survival, so 2 co-primary endpoints. Mentioned already that maybe PCR isn't the best surrogate for long-term cure rates for this, for these kinds of strategies, and so these investigators made an important decision to expand the study to include a co-primary endpoint of event-free survival, and we'll see in a moment why that was so critically important. So the addition of pembrolizumab at the first interim analysis conferred an improvement in pathologic complete response of 14%, and similar to the Impassion 031 data that I just showed you, the benefit was seen regardless of PD-L1 status. And this was the original event-free survival analysis that was presented. This was the interim analysis 2. This was presented after 15.5 months of follow-up, so this was unstable data, but it gave us the first signal from a randomized phase 3 study that we might actually be improving cure rates for this population of people with a delta of 6%. But again, it was unstable at that time with only 15.5 months of follow-up. Recently, though, we saw an updated analysis, interim analysis 4, with more than 3 years of follow-up. And at that point, there was at 3 years, a 7.7% improvement in event-free survival. And for me, this was incredibly exciting. This was a huge bar push a dramatic improvement for our very high-risk patients of almost 8% improvement in cure. And when you look at the event-free survival by pathologic complete response, a small incremental benefit potentially for those who achieve a pathologic complete response, whereas there was a more than 10% improvement in event-free survival for those who did not achieve a pathologic complete response. So again, a very consistent message across trials in that way. In interrogating subgroups, PCR benefits were observed in both positive and node-negative patients. Obviously, the delta is larger for the higher risk node positive patients, but the hazard ratio is actually remarkably similar. So similar relative reductions, but larger absolute reduction for the higher risk node positive subset. And when we look at benefit by stage, same thing, stage 3 patients, larger absolute benefit when compared to stage 2 patients, but very similar hazard ratios, indicating similar risk reduction for both stage 2 and stage 3 patients. And what kind of events are occurring on these, in these patients? So any event-free survival event, 15.7% in the pembrolizumab group versus 23.8% in the placebo group. So dramatic reduction in any event-free survival. And what's notable in red there is the improvement in the distant recurrence rate, 13.1% in the placebo group versus 7.7%. So very consistent with the event-free survival and the overall survival data that we've seen so far. And here's the overall survival data at 3 years and approximately 3% improvement in overall survival. So this was incredible innovation in my mind. We are actually seeing improved cure rates early on in patients with this disease, and the FDA agreed, and on July 27th, the FDA approved pembrolizumab together with chemotherapy for high-risk early-stage triple-negative breast cancer. In their approval, they also approved continued single-agent use in the adjuvant setting after surgery, because that was how the study was designed. And based on Keynote 522, the indication for palliative pembrolizumab from the Keynote 355 study was converted from an accelerated to a full approval. So this became the new standard of care, certainly in the US, but it certainly, at least in my mind, brought up a number of new questions. So let's go back for a second to the GetBar Nuevo study and compare it to the Keynote 522, even though cross-trial comparisons are discouraged. It's remarkable to me how similar looking these curves are with very similar follow-up. Again, in GetBar Nuevo, checkpoint blockade was administered in the neoadjuvant setting only. It was not administered in the adjuvant setting, whereas in Keynote 522, it was administered both in the neoadjuvant and the adjuvant setting. So it begs the question, is all of the immune therapy benefit conferred with the neoadjuvant administration? So Keynote 522 was not designed to ask and answer that question. Sorry, I can't get rid of that. And so we don't have any information about the ability of checkpoint blockade to treat micrometastatic disease. The SWOG 1418 study may tangentially inform us on this question. In this study, patients with residual disease after neoadjuvant chemotherapy are randomized to receive a year of adjuvant pembrolizumab or not. And so this will tell us in a high-risk population whether checkpoint blockade monotherapy may be effective. That data is forthcoming. There's also the A-BRAVE study that also is looking at a similar question with avelumab versus observation. And the Alexandra and Passion 030 study will tell us whether chemotherapy is important in the micrometastatic setting together with immune therapy for the treatment of early stage triple negative breast cancer. So that data is all forthcoming and will nuance our thinking about how to apply these strategies. So I want to be provocative and think about how we might be able to refine our thinking about how we treat triple negative breast cancer. Because again, the Keynote 522 regimen had 4 cytotoxics, and as we'll see later, the majority of the toxicity comes from the chemotherapy backbone. So could we refine our decisions based on patient and tumor characteristics and responses? So I'm going to focus first on the patients who achieved a pathologic complete response in Keynote 522. They did extremely well. There's a not even 2% delta in favor of pembrolizumab, but their 3-year outcomes are excellent. So could that be a population in whom you could forego adjuvant pembrolizumab? Have you already won in terms of curing these patients of the disease, and any additional exposure is all toxicity potential without upside? Also, is this a population of patients who could receive neoadjuvant chemotherapy alone? The control arm here performed very well, and how do you predict for those patients who are going to do extremely well with chemotherapy? And is there an opportunity in selected patients to optimize the chemotherapy backbone? Do we really need 4-drug chemotherapy backbones for all of our triple-negative patients? And especially in this exciting era with novel biologics, antibody drug conjugates, a lot of exciting novel drug development in this space, perhaps rational combinations of those drugs will allow us ultimately to optimize the chemotherapy backbone and minimize toxicity for our patients. The problem is we don't have upfront at diagnosis any predictors of pathologic complete response. We don't know who is going to achieve a complete response. So we don't have that information yet. We desperately need predictors so that we can identify this good prognosis population so that we can pare down the treatment that we give them to get to that excellent outcome. So this is a proposed study for the treatment of this population of patients. For those patients who achieve a pathologic complete response after the Keynote 522 neoadjuvant regimen, could we randomize those patients to receive the 9 additional cycles or 27 weeks of pembrolizumab, or observe them to see if that adjuvant pembrolizumab is really critical? So discussions are ongoing amongst multiple cooperative groups. I also personally think that there's an opportunity to impact the field. We're in a unique position in that we're evaluating these drugs in a typically very young population of women. They don't see that in lung cancer, they don't see that in prostate cancer. So we have an opportunity to contribute to the field. We do not know what the impact of immune therapy is on fertility, and that will be a really important question as we're treating the majority of our young patients with triple-negative breast cancer with these agents. So I think there's a unique opportunity for us there to explore that impact. Now I want to look at the patients who do not achieve a pathologic complete response. And this slide is sobering to me because it reminds me that within 3 years, even the patients who benefited from pembrolizumab, 1/3 of them will have an event. And most of those are distant recurrences that will lead to death. So we need to do better for these patients, and we need to figure out for these patients what rational additional agents we could do to further improve those cure rates. And one thing that I struggle with is how we reconcile the Keynote 522 data with standard of care capecitabine. And of course, this is the CREATE-X data that demonstrated a 5-year overall survival advantage, 78.8% versus 70.3%, with adjuvant capecitabine for those patients with residual triple-negative breast cancer. And of course, on Keynote 522, capecitabine co-administration was not permitted, so Keynote 522 does not ask and answer the question of capecitabine co-administration. And it's hard to ignore an overall survival benefit subsequently demonstrated in a large meta-analysis looking at almost 16,000 patients. That's survival advantage. So we have 2 different kinds of data sets, both showing survival advantage. How do we reconcile? So again, adjuvant capecitabine was not permitted on 522. We don't know about the benefit after platinum and or after immune therapy. And how do we give it if we want to give it? Do we give it concurrently? Do we give it sequentially? And again, of course, Keynote 522 did not ask and answer that question. The only data that I'm aware of that has really informed my thinking on this topic is data generated by David Page, who looked in the metastatic setting at capecitabine or paclitaxel administered in the first or second line setting together with pembrolizumab. And he found that at week 12, there was an overall response rate of almost 50% with capecitabine and pembrolizumab co-administration, and there were no concerning safety signals identified with that strategy. So I speculate that co-administration of adjuvant pembrolizumab with capecitabine could be reasonable in selected high-risk patients with residual triple-negative breast cancer after neoadjuvant chemotherapy. Question number 3, how do we reconcile with standard of care olaparib? We had an FDA approval earlier this year for olaparib in patients with germline BRCA mutated associated cancers. Most of the patients on Olympia had triple-negative breast cancer, and there was a large improvement, as you can see here, in invasive disease-free survival in favor of olaparib in patients who had residual disease after neoadjuvant chemotherapy. They received olaparib for 1 year. And you can see here the triple-negative breast cancer subset, which was the majority of the population, derived tremendous benefit from the addition of olaparib. So what do we do with that data? And how do we give it? Do we give it concurrently? Do we give it in sequence? So again, looking at the metastatic setting, we have 2 studies, Topazio and Mediola, that co-administered checkpoint blockade with a PARP inhibitor with no concerning safety signals identified. And again, cross-study comparisons are discouraged. But if we look at Mediola with immune therapy and olaparib co-administered versus the Olympiad study where olaparib alone was administered, very similar response rates. Now, very different studies, of course, very different population sizes, but it is interesting, and one might question whether there is benefit to be derived from co-administration in the curative intent setting. However, I will be controversial again and argue that I think that it could be reasonable given the absence of a safety signal in selected high-risk patients who have a germline BRCA-associated triple-negative breast cancer. And I'm going to give a shout out to my friend Rebecca Dent because I think that her study, her DORA study, will actually tangentially inform this discussion as well. So in her study, she's taking patients with metastatic triple-negative breast cancer who have a response to chemotherapy and randomizing them to olaparib and olaparib with durvalumab. And that will be the only data that I'm aware of that will directly compare head-to-head olaparib with an olaparib immune therapy combination. And as I said, would tangentially inform potentially our thinking about how to treat micrometastatic disease in the adjuvant setting. And I hope to see that data later in the year. Now, question 4, what about the optimal chemotherapy partners for immune therapy? I already alluded to this earlier. There's a lot of controversy up front about what the best chemotherapy backbone was for these drugs. We've had very discordant data from different studies. Some are positive for paclitaxel, others are negative. Some are positive for nab-paclitaxel, others are negative. So it's not clear to me what the optimal taxane partner is. And then what about the role of platinum? Again, 4 drugs, that's 4 chemotherapeutics. The toxicity comes from the chemotherapeutics. Do we need to give platinum to everyone? And as Rebecca pointed out earlier, the use of platinum has been inconsistent, geographically inconsistent, and in part that's because of these 2 studies, GetBar Nuevo and CLGB 40603, showed improvements in pathologic complete response rates, but did not show statistically significant, consistent statistically significant improvements in long-term outcomes. So a 3-year disease-free survival that was significant in GetBar Nuevo, but a 3-year event-free survival that was not in CLGB 40603. So as a consequence, there were variations in practices in terms of carboplatin administration for triple-negative breast cancer. And then the brightness study was reported, and both arms in the brightness study that contained a platinum had a tremendous improvement in pathologic complete response and event-free survival. And I think that study really drove us to incorporate platinums more consistently in the treatment of our triple-negative breast cancer population. But again, if we're adding in immune therapy and if there's synergy to be had between selected cytotoxic therapies with immune therapy, do we really need all of these agents? And that's the question. What about anthracyclines? Do we need anthracyclines as part of the backbone as well? So the ABC trials and other trials have showed improvements in invasive disease-free survival with the addition of an anthracycline, more than 10% in patients who have node-positive disease. And the Tonic Trial that was mentioned earlier looked at various induction strategies in the metastatic setting prior to immune therapy and found that doxorubicin was the optimal induction strategy in that setting, indicating that doxorubicin might be an important partner for checkpoint blockade. But then we've seen additional data from the I-SPY 2 study that showed that a non-anthracycline-containing regimen performed equally to the anthracycline-containing control. So it's still unclear to me whether an anthracycline is an important partner for checkpoint blockade or not. And what about the impact of dose-dense administration of anthracycline? So in Keynote 522, the anthracycline was administered every 3 weeks. It was not administered in a quote-unquote dose-dense fashion. And we know from pooled analysis of 25 dose-dense studies that dose density improves recurrence rates and decreases mortality. So if we think that dose density is important when it comes to anthracyclines, it usually requires that we also co-administer growth factor support. And what will be the impact of growth factor support on the checkpoint blockade partnership? And the GetBar dues might inform this to some degree. It allows for Q2 or Q3 week administration of the anthracycline component. And depending on how physicians decide to administer the anthracycline, this may inform some of that nuanced thinking. And the next question is about sequencing. I alluded to this earlier. As you'll recall, a subset of patients participating in a GetBar Nuevo study received a run-in with durvalumab prior to their chemotherapy checkpoint blockade co-administration. And this was a subset of patients, relatively small, but an approximately 20% improvement in pathologic complete response, indicating to me that sequencing of these agents potentially matters and that our historical convention of just layering on additional drugs may not be the best strategy to optimize responses to immune therapy. And another question that I get a lot is around radiation therapy. When should radiation be administered with the adjuvant pembrolizumab? So this is a quote from the study. If postoperative radiation therapy is indicated, adjuvant pembrolizumab or placebo may be started either concurrently with radiation therapy or 2 weeks after completing radiation therapy. So there was a sequential and a concurrent option. We haven't yet seen the details of radiation administration from Keynote 522. I am particularly interested in understanding where there was synergy between the radiation and immune therapy for those who received it concurrently. And the reason for that is that that's been a focus of my group and my colleagues at Sloan Kettering and Cedars-Sinai. We thought a lot about how to optimize antigen presentation in our tumors. And of course, we use palliative radiation all the time. And radiation itself causes inflammation, but it also causes tumor destruction. So it can physically break down the tumor into tiny pieces that might be more easily digested by immune cells and therefore might be a perfect partner for checkpoint blockade. And so we undertook a study with my colleague Alice Ho when she was at Sloan Kettering, where we enrolled patients who were with triple-negative breast cancer who were referred for palliative radiation, and we co-administered pembrolizumab together with their radiation. And we had several patients who had durable, complete responses outside of the radiation field, and these were heavily pre-treated patients, including one patient who was without evidence of disease for more than 2 years and ultimately succumbed to other unrelated illness. But she did not require any maintenance therapy. She was drug-free for more than 2 years. So I think that radiation is important consideration with checkpoint blockade administration. And again, I will be very excited to see the Keynote 522 details on that topic. After this session, there's a spotlight poster discussion session that I would encourage you to attend. One of the posters being discussed is a study that we undertook looking at preoperative pembrolizumab with radiation before neoadjuvant chemotherapy. So the idea was to essentially borrow the boost dose of radiation and administer it earlier on in the course of disease while the tumor was still in situ, again with the idea of sort of creating an auto-vaccination effect and co-administering pembrolizumab. And that data will be presented at that session. And I can just tell you that given the results of that effort, a randomized phase 2 study, a pre-op IO plus or minus radiation in triple-negative breast cancer is planned. Our group has also been very interested in other local strategies like cryoablation. Here on the left panel, you can see the tumor, and the black dot in the center is a cryoablation probe. And under imaging, in this case MRI, you can create an ice ball at the tip of that probe, and you can control the size of the ice ball. And then you can see in the right-hand photo that there is tumor debris in the breast cavity. And the idea is really similar to the radiation idea: cause inflammation, bring the cells into the area, destroy the tumor to create antigens that those immune cells can respond to optimize the probability that you'll have a tumor-specific response. And this was work that was done in response to Jim Ellison's preclinical data supporting this strategy. And of course, he went on to get the Nobel Prize a few years ago. I can tell you from our initial effort, which we undertook in 2011 with this strategy, with more than 5 years of follow-up, we've had no recurrences of our patients treated with checkpoint blockade and cryoablation, including our triple-negative subset. So I'm very excited about that strategy. We since undertook a study of dual checkpoint blockade with cryoablation that Elizabeth Coleman led, and we have an ongoing phase 2 study looking at that strategy in high-risk women with residual triple-negative breast cancer. So I think there's an important role to play, not just with systemic therapy combinations, but with local combinations as well. So I'll summarize here by saying that the Keynote 522 regimen improved event-free survival by almost 8% in high-risk early-stage triple-negative breast cancer and has now become a standard of care, certainly in the United States. But as I've just spent the last 25 minutes discussing, for me, it's brought up more questions than answers potentially, and more opportunities to further improve cure rates and mitigate toxicity. The questions that have arisen in my mind is, the first is around the IO benefit in the neoadjuvant setting. Which of our patients can forego adjuvant pembrolizumab potentially? Who can forego checkpoint blockade altogether? There's a population of patients who achieve a pathologic complete response with chemotherapy alone. What can we do to identify those patients at diagnosis? I've explained my concerns about reconciling this data with standard of care capecitabine, which is associated with a survival advantage, and then more recently, PARP inhibition in patients with germline BRCA mutated associated cancer. There are a lot of questions about chemotherapy partners. Obviously, the Keynote 522 regimen that's approved has a 4 chemotherapy backbone, and that's currently the standard of care. But we've had very discordant information around what's the best taxane. Is carboplatin absolutely necessary for everyone, or anthracyclines, impact of dose density, and even sequencing? Then the more recent question was the optimal radiation administration with pembrolizumab. Should we be doing it concurrently, sequentially? And hopefully that data from 522 will be forthcoming. And although I'm incredibly excited about the 522, I mean, we've really pushed the bar in terms of improving outcomes and cure rates for these high-risk patients, which is wonderful. But if 8% of patients are benefiting, that means that 92% of patients aren't benefiting from this regimen. And so how can we further improve on cure rates for those patients and better tailor treatments to mitigate toxicity who don't? There's a lot of opportunity to explore treatment optimization strategies, local strategies like radiation cryoablation. There's obviously a lot of exciting drug development with antibody drug conjugates that I think will factor into these discussions and will be potentially great partners with checkpoint blockade. But at this time, biomarkers, both for prediction of response and toxicity, are desperately needed. Rebecca already showed these guidelines, but this was an expert panel that was recently convened for the Society for Immunotherapy of Cancer that outlines guidelines for the treatment of both curative intent and metastatic breast cancer, and were recently published. And I'm going to be very provocative now. This is not a guideline-endorsed strategy whatsoever. This is my own personal December 2021 strategy for approaching these patients, since I don't have data to answer all of these questions. So for my patients who I'm treating with the Keynote 522 regimen, who do achieve a pathologic complete response right now, I am continuing the standard of care adjuvant pembrolizumab per the 522 regimen, but I'm excited that people are planning the randomized trials of adjuvant pembrolizumab versus observation for that good prognosis population. So I am treating them with adjuvant pembrolizumab per 522 until that data exists. For those who don't achieve a pathologic complete response, I struggle with those ones a little bit more. If they have a germline BRCA mutation, then I do consider olaparib. It could be administered concurrently or sequentially. We've seen, as I referenced, combination data from the metastatic setting indicating that they can be administered safely, but whether there's any synergy to be harnessed with co-administration is not clear. If they do not have a germline BRCA mutation, then I do consider concurrent capecitabine together with adjuvant pembrolizumab. And I am also considering concurrent pembrolizumab with radiation based on that data that I've shown you. Again, this is not a guidelines-based algorithm whatsoever. It's a pragmatic approach in an era where we have really exciting new data and approval with the Keynote 522 regimen, but I can't ignore all of the other survival data that we depended on before that. So trying to find a middle ground that rationally incorporates potential synergies. I'm going to take 2 minutes now just to touch on toxicity, because I think that's really important. It's a multidisciplinary challenge for us. These are slides that Peter presented the other day. It's worth reminding ourselves that most of the treatment-related adverse events come from the chemotherapy backbone, as you can see here. And in the adjuvant phase, there are very few treatment-related adverse events, so that's reassuring. No surprising signals there. And in looking at the immune-mediated adverse events and infusion reactions, there were very consistent results with what we've seen in other studies, with 18% infusion reactions, 15% hypothyroidism, and about 5% of hyperthyroidism, very consistent with prior studies, and reassuring that very few of those immune-mediated adverse events occurred in the adjuvant setting, although I do want to remind all of this, I remind myself all the time, that delayed adverse events can happen even a year after last exposure, so continued vigilance even after patients have completed their course of therapy is critically important, and is again a multidisciplinary challenge. These are another set of guidelines that were developed by SABCS on immune checkpoint inhibitor-related adverse events and are very helpful as guidance to managing these immune-related adverse events. And I think it's really an exciting time to be treating breast cancer and triple-negative breast cancer specifically. I think, of course, we're learning so much more triple-negative breast cancer. The label tells us about what it's not about, the absence of 3 features, but it doesn't tell us anything about what it is about. And I think we're increasingly appreciating that we need to understand the biologic nuance of the tumor microenvironment and the host, and that future decision-making will actually have to incorporate all 3 considerations. And I'll stop there. But again, I think it's a really exciting time with an almost 8% improvement in cure rates in this very high-risk population with the addition of pembrolizumab to chemotherapy. Thank you.